Kishan.
Yes, sir. We can go live.
Just
Yes, sir. We can go live.
Sir, Dr. Balvenkat, sir, are you ready with the slides?
Yes, sir. We are ready, sir.
Okay, fine. Dr. Joshi, sir?
I'm good.
Okay. Dr. Chintala Kishan, our GC member, is just joining in a couple of minutes. So we'll start the program. So very good evening, respected ISA members, ISA leaders, our guest faculty, and dear friends and postgraduates. Welcome to the 14th ISA-AP webinar. I'm very thankful to the ISA leaders and as well as the faculty, Dr. Balvenkat and team for the excellent support for conducting this webinar. Thank you very much, Dr. Balvenkat, sir. So I request our President ISA National, Dr. Olida Joshi, please do the ISA messages. Power to Dr. Joshi, sir.
Yeah.
Thank you.
Good evening, greetings to everyone, and National President of ISA-AP chapter, Dr. Venu, and Secretary, Dr. Srinivas, and past President Dr. Chakrarao, Dr. Kameshwarao, Chairman Scientific Committee, Dr. Balabhaskar, President-elect Dr. Venkat Giri, and excellent faculty, Dr. Balabhaskar and his team. Just me an immense pleasure to join and really congratulate ISA-AP chapter for doing a consistent work. But I also would like to share some good news. Nearly about 7 members from our ISA like a national kind of like ISA have become members for the different committees in WFSA, which is a credible performance. Last 4 years, it was for 6 members. This time we increased number by 1. Maybe another 1 or 2 might join. It might take some time, but I'm very happy to share with you. 7 ISA members have become members of the different committees in WFSA. I congratulate everyone, and that includes Dr. Chakrarao, past president, Dr. Balavenkat, Dr. Balabhaskar, Dr. Venkat Giri, Dr. Muralidhar Joshi, Dr. Usha Lipon, and I think Dr. Matsun Upadhyay. Dr. Matsun, that completes 7 members. It's a good thing. And also, I'm happy, like so often we keep on discussing.
NECM is which Venu was.
And so often we keep hearing like an ISA is not being involved in many of the national programs or maybe national decisions or maybe Minister of Health and Family Welfare. Government, if it doesn't involve ISA, most often it takes opinion from the other institutions and all. That used to be the like usual complaint we used to hear. I'm happy to share. Last 4 months, the Government of India is directly taking help of ISA. I'm really happy about that one. In fact, today I had the meeting with the principal scientific advisor to the Prime Minister of India about the ventilator specification and all. Last 2 months we were working on that one. 80% of the proposal, 80% proposal given by ISA with respect to ventilator standards have been accepted by the principal scientific advisor to the Prime Minister, which is a big number. So it will reach the Prime Minister office some point of time. And of course, it's a big acknowledgement for ISA, not that any dearth of talent, but somewhere we have to keep on creating inroads, keep creating space for ourselves. And wish all the younger generation and all those things a great future in the, in coming years. This and again, I would like to wish the ISA-AP chapter all the best for all study programs, and we hope for an excellent evening. I might have to leave for another couple of meetings, so I request Venu to relieve me. As in, it's time for me to go. Thank you, Venu, once again for calling me. Thank you. All the best for ISA-AP chapter and all the faculty. Thank you once again.
Thank you, sir. Thank you for your blessings and all the encouragement. You can continue whatever work you want. Thank you very much. Dr. Kishan? Dr. Kishan, are you there? Dr. Kishan?
Actually, he was on another meeting along with me.
But just now he called me just a couple of minutes back. He is going to join.
Okay.
Dr. Kishan? Shilpa, please coordinate.
In the participants list, I can't see Kishan, Dr. Kishan here.
Kishan Chintala.
No, sir.
Joshi, we will continue that.
I think continue the topics and all. He can always join and he can always check in between lectures. Also, you can invite and ask him to share his thoughts. Nothing wrong about it.
Okay, sir.
Yeah, please
Dr.
go. Please go ahead.
Balbhaskar, sir. Dr. Balbhaskar, sir. Dr. Balbhaskar and Dr. Kameshwar, the two persons are the today.
Yeah, I did. Yeah, they can. Okay, actually, they're not joined. Okay.
Not. Shilpa, please check for Dr. Balbhaskar.
No, sir, not yet joined. Balabhaskar, sir, Kameshwar was not yet joined.
Okay.
You can ask Dr. Giri to. Ask Dr. Giri to chair, no?
Yeah. Dr. Venkatagiri, sir. Dr. Venkatagiri.
And ask Dr. Giri and Dr. Chakra Rao to chair. Nothing wrong about it.
Dr. Venkatagiri, Dr. Chakra Rao, sir.
Request them to chair. Nothing wrong.
Giri, please introduce today's speakers.
Okay, right.
Sir, are you on Earth or outside Earth?
I am in the Earth only. I am in the Earth.
So today's speakers, Dr. Balbhaskar and Dr. Santosh. So please introduce Dr. Giri. Dr. Chakragar, are you there, sir? Okay, please continue. Giri.
Yeah, I have to introduce Dr. Balavenkat. Okay. Yeah, it is my great pleasure to President Venu, Secretary, past President Chakra Rao, President Dr. Joshi, and dear friends, it is my honor and pleasure to introduce Dr. Balavenkat. I don't think he needs an introduction. It will be a disgrace if I tell him who is Balavenkat. Yeah, see, he is a big man in the regional anesthesia. I will not tell anything about Balabhaskar. Wherever you say that the name of regional anesthesia, first name is coming of Dr. Balavenkat only. He is the consultant in Ganga Hospital and Medical Center, Coimbatore, and academic director. And he is the founder, president of RA, and he is currently the regional anesthesia president of Asiana-Oceania. Is it Asiana-Oceania, Bala?
Asian Oceanic Society.
Asian Oceanic Society. And he is in the scientific committee of World Congress of Anesthesia, and there are many more. And is a governing council member of ISA. And I think if you tell anything more, well, you will be knowing more than me if I tell that. With this brief, I present my good friend, Dr. Balavenkat. And meanwhile, I congratulate him for being elected to the WFSA committee member, educative committee member of this thing. With this, I think Chakra Rao Garu will introduce Santosh. Thank you.
You congratulate yourself first for being elected as the committee member for the professional well-being.
Okay.
Who is the speaker?
Sir, Dr. Santosh, who is a consultant anesthesia. Sir, I will introduce him, sir.
Okay, that is better. I am not.
Sir. Yes, sir.
Okay.
Balvenkat, sir. So please continue. Thank you.
Okay, sir. Respected President of National ISA, Dr. Muralidhar Joshi, the doyens of anesthesia, the past President of ISA, Dr. Chakra Rao, the President-elect, Dr. Venkatagiri, Dr. Balabhaskar and Dr. Kameshwar Rao, who will join us. And on behalf of the Department of Anesthesia, Ganga Hospital, I have great pleasure in thanking the President of the ISA-AP chapter, Dr. Venugopal, Secretary Dr. Srinivas, for consistently and constantly trying to improve the academic dissemination of information to all the people, including the private practitioners across the state of Andhra Pradesh. Sincerely thank you for these opportunities that are created, and you're doing it consistently. So thank you so much to the ISA-AP chapter led by Dr. Venugopal and Dr. Srinivas. I also take the opportunity to congratulate Dr. Venkatagiri and Dr. Chakra Rao and all the other 5 members of ISA for having taken over the responsibility in the World Federation of Society of Anesthesiologists. Clearly indicates that India has got a big role to play in the international forum. And I think time has come to show the world that India can accomplish a lot of things that the world is looking for. With these introductions, today we are going to go into the lower limb blocks. Upper limb blocks are one which are practiced usually, but now we have several challenges when we give anesthesia to critically ill patient, especially, for example, if you have a patient who comes with a diabetic foot, with a low ejection fraction, who is on dual antiplatelet therapy because of the coexisting coronary artery disease, and he comes with a bad cellulitis which needs an immediate debridement. And you also know that in a critically ill patient with a diabetic foot, with multiple organs involved, with urea creatinine raised and low ejection fraction, coronary artery disease, general anesthesia would be a concern, and giving neuraxial block will be a concern if the patient is on dual antiplatelet therapy. So if you want to confront this challenge, and if you want to provide a safe anesthesia, I think one of the best ways to do is to go for lower limb blocks. And if you get a patient like this, a diabetic foot needing an emergency procedure, including if the patient is having diabetic ketoacidosis, removing the source of sepsis is the best way of treating ketoacidosis. So you will go for a popliteal sciatic block with a saphenous block to give a superb analgesia, and the whole surgery can be done there without producing any hemodynamic disturbances. Similarly, a patient who comes with a trochanter fracture, a geriatric patient who comes with a trochanter fracture, instantly you can make them pain-free by giving an excellent femoral block, immaterial of when you want to do the surgery. The minute the patient, this we call it as an on-arrival block. So all the hip fractures which come into the hospital, whether it's day or night, we have anesthesiologists doing the duties. One of the part of the duty is to make sure that instant block is given for all hip fractures and make them pain-free. In that, we do either a femoral block or a 3-in-1 block, or we do a fascia iliaca block, or we do a articulating branch of the hip joint block. So, but the PENG block recently, but just to make sure that the patient is pain-free. And I just wanted to kickstart this with yet another case which we recently had, a 42-year-old male who came with the dislocation of the ankle. He was a diabetic and hypertensive, and his pressures on arrival was 240/140. He's a diabetic with the sugar when he came was about 400. And he was a known case of coronary artery disease, triple vessel disease, angio-approved, and he was advised a CABG. And the relatives didn't want to undergo a surgery because of the risk explained. So he was managed conservatively. So he was on both clopidogrel and aspirin. He also had deep vein thrombosis. So he was on taking warfarin, and his INR on arrival was 2.4. He had a renal dysfunction with elevated urea and serum creatinine. He was a hypothyroid, and he was on replacement drugs for that. Obese patient. He was full stomach on arrival because he had his lunch, fell down in the bathroom, developed an ankle dislocation. So when a case like this comes, it produces a profound challenge to the anesthesiologist. But this challenge can be converted into nothing by doing a very site-specific analgesia. So when you do, this patient had a popliteal sciatic block and a saphenous block given. Within minutes, within 15 minutes, you saw the pressure which was 240/140 become 140/80. So the best cardiologist for this patient was not a cardiologist, but an anesthesiologist who can offer a pain relief and bring down his pressures. And he underwent a close reduction. And since there was a lot of swelling, the case was postponed for the next 4 days. And again, the case was done under a block with fixation done. So it clearly shows that the modern day anesthesiologist has to have great insights into the lower limb blocks. It's very handy. And today we are going to discuss both the peripheral nerve stimulator used blocks for the femoral and the sciatic, and also the ultrasound guided block for femoral and sciatic. I have with me two of the experts, Dr. Vipin Goyal, who will share the thoughts with us. Initially, I was supposed to speak, but he's a great proponent of the femoral block. So I've requested him to present the peripheral nerve stimulated guided femoral block and sciatic block, which will be followed by Dr. Santosh. Santosh was a postgraduate and later graduated. He did his fellowship with us in regional anesthesia, and then he has become a consultant. So both Vipin Kumar Goyal and Santosh did the fellowship here and then consecutively followed it up with being a part of the consultant team, and they do excellent regional anesthesia work. I have great pleasure in having Vipin present the PNS part and Santosh doing the ultrasound part. Now open to Vipin to start the presentation on peripheral nerve stimulator guided lower limb blocks.
So slides are visible.
Yes, sir. We
Yes,
can
yes,
see
yes.
the slide. Yes. Yes.
Good evening to all my seniors, friends, and colleagues. So thank you, ISA-AP and Dr. Balavenkat sir, for giving opportunity to talk on PNS guided femoral and sciatic nerve block. So we'll discuss today on how we can, like Bala sir told, how we can do simple procedures, and even in emergencies cases we can perform the surgeries under blocks. So as we know, upper limbs, we can do surgeries by blocking single brachial plexus block. Similarly, in lower limb, we can block lumbar plexus and sacral plexus. There are two plexus which can block and perform the surgery. So there are different branches of lumbar plexus and sacral plexus which can be blocked and perform the surgeries. So through lumbar plexus, we have femoral, which is the main branch other than obturator and branches, and the sacral we have a main branch of sciatic nerve which we can block and perform the surgeries. So for performing the procedure, we first know what are the dermatome, myotome, and the osteotome of the surgeries to know which nerve to block and how according to the procedure, which procedure we have to do and which nerve is required to block. So like if we see in this image, if we see this is the dermatomal supply. If you see anterior and medial part of the thigh, which is mainly supplied by the femoral, and medial part of most medial posterior medial part is by the obturator nerve, and posterior part is supplied by the posterior femoral cutaneous nerve. And below the knee, if you see, it is mainly by the saphenous, which is a terminal branch of femoral nerve only, and lateral part by the common peroneal nerve, which is a terminal branch of sciatic nerve. So this is important for while performing the block, which part of the leg is going to be operated. Similarly, this is the osteotomal supply. If you see here, the anterior part is supplied by the femoral nerve, medial part is supplied by the obturator nerve, below the knee mainly supplied by the sciatic nerve. So if you want to perform surgery below knee, so only osteotome, the sciatic nerve is sufficient. But if you want to do surgery on the thigh, then you have to block femoral and obturator nerve both. So this will help in decision making which nerves is required to block, to which part of the leg is going to be operated. Similarly, myotome. If you see here, the quadriceps are basically supplied by the femoral nerve and sartorius, while the adductors are supplied by the obturator nerve. And similarly, below the knee joint, all the muscles are supplied by the sciatic nerve, tibial nerve, and the common peroneal nerve. So if you want to operate below the knee, you have to block the sciatic nerve for myotome and osteotome. While dermatome, only medial part is supplied by the saphenous nerve, while lateral part and posterior part is supplied by the sciatic nerve. So basically, if you want to do any surgery below knee joint, you have to supply the block the sciatic nerve, and only medial part you have to block the saphenous nerve. While if you want to perform a surgery on the thigh, then you have to block both femoral nerve for a dermatome, myotome, and osteotome, and posterior part is supplied by the sciatic nerve. So now this is the basically main before performing block you should know, and you have to imagine what are the nerves we have to block. Now first we'll see what is the femoral nerve. First we'll go a bit of anatomy, then we'll go by the block. So if you see the femoral nerve, it is the main branch of the lumbar plexus block, and is the dorsal division of the anterior MI of L2 to L4. It is the largest branch, and when it descends down, it will go into the groove formed by the psoas and the iliacus muscle. And at the inguinal ligament, when it emerges, it will divide into the anterior and posterior branch. At this level also, it is located lateral and posterior to the femoral artery, where it is superficial. So if you see schematically, you will see that it is the anterior branch, and this is the posterior branch. Anterior branch will supply the sartorius and the pectineus muscle, while the posterior branch supplies all the quadriceps muscles and terminate as a saphenous nerve. I have divide and make it like a little simple. Like if you see femoral nerve divide into the anterior and posterior branch, then anterior if you see motor supply and sensory and articular branch. So if you see anteriorly motor branch, it will be supply the sartorius and pectineus. Sensory is the only anterior medial thigh, and articular branch to the hip joint. If you see the posterior branch, so it will supply the quadriceps muscles. Sensory will be the on the saphenous nerve. And then in quadriceps, there are 4 quadriceps muscles, rectus femoris and 3 vestae, vastus medialis, intermedialis, and the lateralis. So all these 3 muscles, vestae will give the articular branches to the knee joint, while now to rectus femoris will give articular branch to the hip joint. So this will help you to which nerve to block, whether you need an anterior branch or you need a posterior branch, or you need a full femoral nerve to block. You can selectively block, and this much is required to block a femoral nerve, right? At the inguinal ligament, if you see, that is the skin subcutaneous tissue. These are the fascia lata. This slide is important to see, like while performing the block, where there is a tactile sensation to see, feel the 2 fascias, fascia lata and fascia iliaca. Here you will see the nerve is sandwiched between the 2 layers of fascia iliaca, above and below. So while performing the block, when you pierce the needle, you will feel for the resistance offered by the fascia lata and the fascia iliaca. So that is the 2 pops you will feel while performing the block by landmark technique. And by nerve stimulator also, you can feel those 2 pops. So you are sure that you are performing in the right direction. You are going into the right direction. So this is the fascia lata, this is the fascia iliaca, femoral artery, femoral nerve, and femoral. This is the femoral nerve. This is the iliacus muscle, and this is. So what are the indications of femoral nerve? As I told, this can be used as an analgesia purpose or for the surgery purpose. If you want to perform for analgesia purpose, like in our institute, we use for as a on-arrival block for like neck of femur fracture, shaft femur, subtrochanteric fractures, or as a post-op analgesia in knee arthroscopy patients, patella fractures repairs, THR patients, TKR patients, or for surgeries in thigh, like superficial procedures of the thigh, skin grafting, quadriceps muscles or tendon biopsies, long saphenous vein stripping, harvestings. So these are the indications for the femoral nerve block. These procedures we can perform only under femoral nerve block. So there is no absolute contraindications to perform femoral nerve block, but there are some relative contraindications, like if any previous ilioinguinal surgery has been performed, or if there is any pre-existing femoral neuropathy in diabetes and all, or there is any large inguinal lymph nodes or tumors arrival which is hampering the performing the block, or if there is any infection at the local site of the performing at the site of the block. So what are the landmarks to perform a block? So in this, patient will put the patient in supine position, then we'll draw a line joining the anterior superior iliac spine with the pubic symphysis. That represents our inguinal ligament. Then we'll palpate for the femoral artery and mark it at the inguinal crease, which is around 1.5 to 2 centimeter below this line, which inguinal ligament line, which we joined anterior superior expand to pubic symphysis. Below this line, around 2 centimeter down, we'll palpate for femoral artery and mark it. So our needle entry will be this lateral to this mark, around 1 to 1.5 centimeter lateral to this artery. And at this because at this location femoral nerve is superficial, wide, and the needle does not pass through significant muscle mass, so there it will be less painful to the patients. And needle direction should be cephalad, around 35 to 30 to 45 degree angle cephalad. So that will be the direction. It is anterior superior spine. This is the pubic symphysis, inguinal ligament, around 1.5 to 2 centimeter down. This will be our artery, then 1.5 centimeter lateral to it. This is our needle insertion point, and we'll go cephalad direction. So we can use 22 gauge 5 centimeter insulated needle, or if you want to perform a catheter, then we can use 18 gauge 5 centimeter insulated Tuhi needle for putting the catheter for the infusions. Then we start with the 1 to 1.5 milliampere nerve stimulator, and we'll look for patellar snap, that is because of quadriceps contractions, and we'll decrease the current till it less than 0.5 milliampere, 0.3 to 0.5 milliampere, and at that point we'll inject drug around 20 to 30 ml of local anesthetics. We can use 0.5% bupivacaine, 0.75% ropivacaine, or mixture of 2% lignocaine with ADR plus bupivacaine. So this is our block tape before performing the block. This is our nerve stimulator we used. These are in needles, 5 centimeter and 10 centimeter needles. And this is the lipid. Without this, we never perform our blocks in our. So this is the most important thing. That's why I put it in the. Without this, we never perform our block anyway. This is my home message also, that you should not perform if this is not available nearby. So whenever you are performing any block, this lipid, cellular lipid, any intralipid should be available in surrounding areas. Because and even in PNS guided, we are using little bit higher volume, so chances of local anesthesia toxicity is more. So it should always be available. So we'll see. So we'll see how we perform the PNS guided femoral nerve block. We'll inject cephalad direction, then we'll look for patellar snap, then we'll decrease the current till it will reach less than 0.5 milliampere. In this video, we are putting catheter also. See, patellar snap is coming. This is also called dancing patella. Then we'll look for backflow also. Then we'll pass the catheter and we'll fix it. So clinical pulse tips you will see whenever you perform this block. First, whenever you entered and first you encountered is the sartorius stimulation. So that is the contraction of the lower medial thigh. So that you should not accept. That is because of the anterior branch of the femoral nerve that is supplied the sartorius muscle, and that causes the contraction of the lower part of the medial thigh. And so you have to go further, advance the needle tip till you lose the twitch or you get the patellar snap. If you did after going further deep, you didn't get the patellar snap, then you come out and redirect the needle bit lateral and deeper, because posterior branch is usually lateral and deeper. So our target is posterior branch of the femoral nerve. So I will show you video which response you should not accept and which you should accept. So my needle direction is cephalad with 35 to 40 degree angle. This is the local twitch. So what usually we'll see. So we'll see that its contraction is coming, but this is usually because of sartorius contraction, and this you should not accept. This is the patellar trap, or this is the quadriceps contraction. We should accept this one, not the earlier one. So this is the actual right contraction. So there is no absolute contraindications for the femoral nerve block. So now we move to second block, which is sciatic nerve block. So sciatic nerve block, will go a bit of history. It was first described by Victor Pauchet in 1920. He described, he described that join the line between greater trochanter and posterior superior iliac spine, and from midpoint you go 3 centimeter perpendicularly, and that was explained by Labat in his literature in 1923, and is famous as classical Labat's approach, which was later modified by Vinis by joining one more line from greater trochanter to the he joined the line from greater trochanter to the then in 1975, Raj has modified this technique. In the supine position, he performed this block. Now for perform this block, we should know the sciatic, how it goes from course of the sciatic nerve. So after emerging from the sacral plexus, sciatic nerve enter into the from the pelvis, it enter into the gluteus hip area through greater sciatic foramen, and into anterior to the piriformis, and posterior to the inferior gemmelli, superior gemmelli, and obturator internus. Then it descends further down in front of the descends down in front of the biceps femoris, and anteriorly it was covered by the adductor magnus, and at the in the popliteal fossa it will divide into the tibial and the common peroneal branches. So as you see, it will be covered by the piriformis muscle posteriorly, and then it will go and it at the level of the ischial tuberosity, and it will greater trochanter. The sciatic nerve will be covered by the long head of the biceps femoris. Then at the popliteal fossa it will divide into the tibial nerve and the fibular nerve, common peroneal nerve. So there is a evoked motor potential response. So when you stimulate the sciatic nerve, so there are response you will get like plantar flexion, dorsiflexion, eversion, and inversion. So which response you will accept and which response you will not accept. So there are 4 response: plantar flexion, dorsiflexion, eversion, and inversion. So out of this, there are different muscles which will cause these responses, and there are different nerves which are causing that. So like plantar flexion, it was caused by the gastrocnemius and peroneus longus and peroneus brevis, and which is supplied by the tibial nerve and superficial peroneal nerve. Similarly, the inversion, which is caused by the tibialis anterior and tibialis posterior, and the nerves are supplied by the deep peroneal nerve and the tibial nerve. So if you see these two, plantar flexion and inversion, these are supplied by both the nerves, which is the terminal branch of the sciatic, tibial nerve and the peroneal nerve. So our aim is to we have to accept either plantar flexion or inversion, because dorsiflexion and inversion both are supplied only by peroneal nerve. So whenever we stimulate the sciatic nerve, our target is either plantar flexion or inversion or both. So sciatic nerve, this is sacral plexus block, provides both motor and sensory innervation to the entire limb, hip, ankle, knee. So twitches are palpable twitches of hamstrings, calf muscles, foot and toes. Patient needs adequate sedation because they are deeper blocks and we have to cross lots of muscles while performing this block. So it is a painful. So we need a bit sedation to these while performing these blocks. Onset will take 10 to 25 minutes and will provide complete anesthesia of the leg, except medial part, which is supplied by saphenous nerve. So we have to supplement while performing on the medial side of the, if skin incision is on the medial side of the skin. So indications for the sciatic nerve, all lower limb surgeries, analgesia for knee surgeries involving posterior compartment, below knee amputations. For contraindications, basically, or if any local infection, bad sore at the site of insertion, coagulopathies, allergy to the local anesthesia, or pre-existing any nerve system disorders. So there are many techniques at various levels we can perform sciatic nerve blocks, like at the transgluteal approach, transgluteal level by Labart's approach, parasacral approach by Mansour's, at subgluteal by Raj approach, infragluteal by Sukhani's approach, Gardini's subtrochanter approach, popliteal approach. So today we'll see parasacral approach by Mansour, subgluteal by Raj approach, and popliteal approach. So at the gluteal level, if you see the nerve, when it come out of the greater sciatic foramen, posteriorly it was covered by the piriformis muscles, and anteriorly it was by the inferior gamillae, superior gamillae, and the obturator externus. And this is the gluteus maximus, which is cut down here. So when we perform the block at the level of gluteal, this is at the level of the parasacral approach, and this is at the level of the subgluteal level we'll perform. So while performing Mansour approach, patient should be in the lateral position and will mark the posterior superior iliac spine and ischial tuberosity. Then we'll join both the points, and then we'll go 6 centimeter caudal from the posterior superior iliac spine on that line. And that is this point is our needle insertion point. And we'll go perpendicular on this point in all planes, perpendicular to the skin, perpendicular to the floor, parallel to the floor. And as we go in, we'll look for the twitches of the hamstrings, calf muscles, foot and toes. At this level, the nerve to hamstring is in the substance of the sciatic nerve. So even the contraction of the hamstring is acceptable in this approach only. So if we see the contraction of the hamstring while performing at this level is acceptable, and we have seen this 100% if block has been taken, if we see the hamstring contraction by this approach. So there is a small video on this. If you see this, we have marked. This is the posterior superior iliac spine. This is the ischial tuberosity. This is the 6 centimeter down. This is the local twist with the gluteus maximus and pectinis. And then you see we have manipulated the needle and gain deeper. And then there is a hamstring contraction will come. Yeah, there starts coming contraction of hamstrings. You can see this. Yeah. It's visible. So you can accept this hamstring contraction because at this level, hamstrings now to hamstring is still in the substance of sciatic nerve. And you can look for the contraction of the toes also, if visible. In this particular case, we have. So in this approach, there is other nerves which also get blocked while performing. These blocks are gluteal nerves, posterior cutaneous nerve of thigh, obturator internus nerve, and pudendal nerves, perineal nerves, quadratus femoris, and splanchnic nerves also. There are some benefit also. There are some side effects also. because if you are performing surgeries on the posterior side of the thigh or posterior side, so posterior cutaneous nerve of thigh is required. Operator side on the posterior medial side if required, then operator internus is required. But the side effect is there is urinary retention because of pudendal nerve, and there is a perineal anesthesia happened if the perineal nerves are involved, and there is a operator nerve involvement is there while performing at this level, and these are the area which get blocked after performing this. Posterior cutaneous nerve of thigh, peroneal nerve, sural nerve, all these will get blocked in this. Now we'll come down from parasacral to subgluteal region. At the subgluteal region, if you see, the nerves is very superficial, and the gluteus maximus muscle has been thinned out here. So this is the superficial, most superficial part where the sciatic nerve has come out. So this is the less painful as compared to the parasacral or gluteal region block, and it lies between the groove formed by the biceps femoris and the semimembranous semitendinosus. If you see here, this is our target area where you will perform our subgluteal. So subgluteal we can perform by Raj technique. In this patient position will be flexion at the hip joint, flexion at the knee joint, will mark for the greater trochanter and the ischial tuberosity. So greater trochanter and ischial tuberosity, and the midpoint of it perpendicularly will go and will look for the contraction of the plantar flexion and inversion of the toe. As we see, there is a plantar flexion we are able to appreciate. Then we'll start decreasing the current. So at less than 0.5 also the contractions are coming. So advantage of the subgluteal, as I told, it does not require lateral position. In supine position we can perform. It's convenient as the nerve is easily accessible. It is more superficial, and gluteus maximus is thinned here, so it's less painful. Now we'll come further down. It's the popliteal sciatic block. As we know, before performing popliteal fossa, it is a quadrangular space bounded by semitendinous muscle on one side and biceps femoris, and gastrocnemius side on the both sides. And here the sciatic nerve will divide into the tibial and the common peroneal nerve. So our target is just before bifurcation, or before bifurcation we have to target. So popliteal block performed on sciatic nerve just before bifurcation. Around it will bifurcate just 7 centimeter from the popliteal crease. So our landmarks will popliteal crease, biceps femoris tendons, and semimembranous and semitendinous. This we can, by flexing the leg at the knee, we can make the biceps femoris and semitendinous tendons prominent, and we can mark them. It will help in anestherizing the entire leg below the tibial plateau, except the skin on the medial side, for which we can supplement by saphenous block, used for distal lower leg and foot or ankle surgeries. So we see this is semimembranous semitendinous on the medial side, biceps femoris on the lateral side, popliteal crease. This is around 7 centimeter. This is the midpoint of this tendons, semimembranous semitendinous on the medial and biceps. We take the midpoint of these tendons, midpoint, and 7 centimeter from the popliteal crease. This is our needle insertion point. Patient position in the prone or modified exaggerated position means leg to be blocked uppermost, flex at the knee, touching the bed, underlying leg straight. That is the exaggerated position. Practitioner position on the side of the patient, palpating for the biceps femoris, for tendon. Then we'll start with 1.5 milliampere current, and then we'll go start stimulating. If needle is in the correct plane, there will be no local muscular twitch. Will directly stimulate the sciatic nerve. First response what we'll get is the sciatic nerve. There is no, and while entering into the needle into the sciatic shield, you will feel a facial click. So this is while performance. So advantage of popliteal sciatic block is there is improved calf tourniquet tolerance as compared to the ankle block. There is a mobile foot, while in ankle block it is not possible, and there is last longer as compared to neuraxial blocks. So while performing tips are patient with long-standing diabetes, peripheral neuropathy, sepsis, and peripheral, you can accept current up to 1 milliampere is accepted. And when there is a small change in needle position, and if you get the motor response, tip is move along that, like if you getting the tibial response, and if you move little bit on lateral and medial side, if you are getting the peroneal response also, that means you are at the above the bifurcation. For a complication as such in sciatic nerve blocks, there is in chances of infection. There is a chances of, if you're at a higher level, chances of pelvic perforation of pelvic organ, hematoma, vascular punctures, last nerve injury, anesthesia of the pudendal nerve. Thank you.
Yeah, thanks, Vipin. Of the blocks that you saw, in these two things, I think two things everybody should master, and very simple to give. One is the femoral block, and other is the sciatic block. In the sciatic block, I think one of the things which easily can be performed even by the postgraduate is the subgluteal sciatic. The subgluteal sciatic is very, very easy to give because on either side you have a bony landmark. The greater trochanter on one side and the ischial tuberosity on the other side. What I would suggest is, if you have not given a block like this before, I would request everybody to palpate the subgluteal sciatic landmarks when you give a general anesthesia to the patient before positioning for any other procedure. Just to palpate the ischial tuberosity and the greater trochanter, and draw a line between, imaginary line between the two, and go to the midpoint and use a 100 centimeter needle, the stimuplex needle. And here the nerve is quite big. So invariably, at a depth of about 5 centimeters, you will get the desired evoked response. And this block is extremely useful when you get a sick patient with diabetic foot. This should be mastered by every postgraduate, and it's easiest to give. And the other one is the femoral block, which he described. So at the level of the inguinal grease, you just go below that, palpate the femoral artery, and at the just below the inguinal grease, palpate the femoral artery 1 centimeter lateral to the femoral artery, make the first point, and just 1 centimeter below the first point, you make the second point. Use a 50 millimeters needle, go directly inside, and as Vipin said, that look for the quadriceps contraction, the patellar snap, and give the drug. So these two blocks will be extremely handy even for a fresher to start, and the success rates are very high even with a peripheral nerve stimulator. Having seen all this, now we will move to the sonoanatomy. How do you use the ultrasound machine and effectively give a femoral and a sciatic block? And now to do this, I request Dr. Santosh, a consultant anesthesiologist working with us, who did his DNB here, then he did his fellowship here, then he became a consultant. So over to Santosh Kumar to take over the journey of the lower limb blocks with the help of an ultrasound.
Good evening to everybody. I thank the members of the ISA Andhra Pradesh chapter and Dr. Bala Venkat for giving me this opportunity to present my experiences on the ultrasound guided femoral and sciatic nerve blocks. So a short anatomy about the femoral nerve. Actually, sir, Dr. Vipin has said about the lumbar plexus. It is one of the largest branch of the lumbar plexus, having a root value of second cargo. Yeah. Actually, the nerve exits the pelvis via the just behind the inguinal ligament in a groove. It actually comes via muscular groove that is nothing but the iliacus muscle and the psoas major. So once it enters the femoral triangle, it lies deeper to the two fascias which covers the femoral triangle. It's nothing but the superficially the fascia lata and the fascia iliaca, which is deeper to it. So this fascia iliaca is nothing but the fascia which covers the iliacus muscle, and it also covers the femoral nerve, and it separates the femoral artery from the femoral nerve. This is just a schematic diagram of the below the inguinal ligament area. You can see the fascia lata, which runs superficial to the artery, whereas the fascia iliaca, which runs deeper to the artery, and this fascia actually separates the artery from the nerve. Okay, so that's why it's always important to give the drug deeper to the two fascias. Yeah, in this schematic diagram, you can see that the fascia lata running superficially, whereas the fascia iliaca just smearing over the iliacus muscle, covering the femoral nerve and going deeper to the artery. So this fascia actually separates the artery from the nerve. So as Dr. Vipin sir has said about the divisions of the femoral nerve, it's actually divides into anterior and the posterior branches. The anterior branch usually it's most of a muscular branch, and whereas the posterior is important for our analgesia purpose. And indication wise, the surgical part, if we require a split skin graft of the anterior thigh and any surgeries below the knee, usually on the medial aspect of the leg, and repair of the quadriceps tendon, or the many small procedures like muscle biopsy, we can do it under a simple femoral nerve block, and long saphenous vein stripping, and usually it is given as an analgesic block for femoral neck, shaft or patella. This block can also be used as a on-arrival block, and combining with sciatic, we can give this block for hip dislocations, knee dislocations, and patellar dislocation reductions, and for total knee arthroplasty analgesia. And if it is supplemented with sciatic or a popliteal block, it gives a complete anesthesia of the leg and the ankles. Okay, approaches and techniques for the infra-inguinal approach. The transducer is placed just parallel to the line joining the anterior superior iliac spine on the lateral aspect and the pubic tubercle on the medial aspect. Actually, the misnomer is that keeping a probe on the femoral crease usually shows a divided femoral artery. At this point, you can notice that the femoral nerve is also divided into multiple branches. So if you give a block at this point, the chances that you can miss few branches. Whereas if you go a bit more proximal, you can see the artery as a single artery. And at this point, the nerve is also not yet divided. Usually infra-inguinally, the nerve travels just a 3 centimeter distance, and it arborizes completely. So you have to catch the nerve in the 3 centimeter. So for that, the clinching point is keep the artery as a single unit. So in this picture, you can see the fascia iliaca, which smears over the facial muscle, iliopsoas muscle, and then it separates the nerve from the artery. So this is the clinching point which has to be remembered while giving a ultrasound guided femoral nerve block. So an important point about femoral nerve, ultrasound guided femoral nerve block is the anisotropy. Few people tend to scan the inferangular region and they will not be able to visualize the nerve properly because the nerve and the muscle, everything has an similar ecotexture. So in order to make out the nerve and bring the nerve out of this uniform ecotexture, you have to tilt the probe either caudally or cranially. So this this maneuver makes the reflected beams from the nerve more. So the echogenicity improves if you cut the nerve in a perpendicular axis. So just a simple representation of this anisotropy. So when I tilted the probe cranially, you are not able to see any neural structure here. Whereas if you tilt the probe caudally, you can see the nerve getting visualized properly. So for performing this block, so needle tip has to be placed below the fascia lata and the fascia iliaca. So this is very important, and proper deposition of femoral nerve being visualized by the displacement or the local anesthetic surrounding and separating the nerve from the fascia iliacal layers. So this is the so I have made the artery as a single, and can you visualize the hyperechoic structure running above the artery and a hyperechoic structure running above the nerve, separating the nerve from the artery? I'm introducing the needle from the lateral aspect. So here you can see the nerve. So either you can keep the
Shilpa, is there any problem? Shilpa, is there any problem?
Sir, they have lost the connection. They have lost the connection. They have to rejoin.
Yeah, please coordinate. Thank you. Their internet signal is poor, maybe.
Yes.
Any audio problem?
Sir, unmute yourself, sir. Bal Venkat, sir. Unmute yourself. Yes, unmuted. Yes. Sir, please proceed.
So this is purely a sensory nerve block, and it preserves the muscle power. So that's why it is being advisable for early mobilization in case of THR patients and even IT fracture patients. So this is the schematic representation of the articulating branch of the femoral nerve. It's nothing but the branch of the femoral nerve which lies between the summit of the three muscle. It's being so in this schematic representation. Yeah. So in this schematic representation, the nerve lies between the three muscles. It's being superficially covered by the sartorius muscle, and medially by the iliopsoas muscle, and laterally by the rectus femoris muscle. So it usually is being visualized in the same as the femoral nerve in the inguinal region. The femoral artery is being visualized, and then the probe is slowly moved laterally 3 to 4 centimeter, and the probe usually lies just below the anterior sphenic spine. So usually the nerve looks as a triangular structure at the summit of the three muscles. Okay. So usually the sartorius superiorly, rectus femoris laterally, and the iliacus muscle medially. So this is a video showing the structures. So by moving laterally, you can see a boat-shaped or a triangular-shaped muscle, which is nothing but the sartorius muscle. And just lateral to it is nothing but the rectus femoris, and just medial to this nothing but the iliopsoas muscle. I put the needle from the lateral to the medial aspect, and coming to the summit of the three muscle, you can see the spread of the drug, and you can also see the nerve in the summit. So it is just below the anterior sphenic spine. Okay, so we'll deal with the next block. It's nothing but branches of the femoral nerve, and this adductor canal block. So why we should emphasize more on an adductor canal block rather than giving a proper femoral block? So it is also purely a sensory block and allows early mobilization because it preserves the muscle strength of the thigh. And anesthesia and analgesia for TKA surgeries, knee arthroscopies, patella surgeries, and all arthroscopic procedures, and then superficial surgery on the middle side of the leg. So usually the stripping of the saphenous vein can be done alone with this block. Whenever this block is being combined with the popliteal block, so we can perform surgeries below the knee. So a small introduction about the anatomy of the adductor canal. This adductor canal is nothing but a triangular structure which is being bounded. This is a triangular structure which is being bounded laterally by the vastus medialis and medially by the adductor longus at the upper part and the adductor magnus in the lower part. And it is being covered by the sartorius muscle. This sartorius muscle is usually moves from the lateral to the medial aspect of the thigh. And just moving below in the adductor canal, you can see a more membranous structure, nothing but the vasoadductor membrane. So when the vasoadductor membrane starts, it forms the proper adductor canal. So this is the sartorius muscle which moves from the lateral to the medial aspect, covering the nerve, artery, and the vein. Okay, so this structures whichever lies below the sartorius muscle is nothing but the adductor canal. And once it has been removed, we can start that the artery, vessels, and the nerves enters the adductor canal at the apex of the femoral triangle. This is the femoral triangle, and the apex forms the upper part of the adductor canal. Whereas the lower part of the adductor canal is nothing but the hiatus in the adductor magnus, where the vessels enters the popliteal fossa via this hiatus in the adductor magnus and goes posteriorly. So the contents of the adductor canal, because the adductor canal's contents varies from various positions, from the proximal, middle, and the distal part of the adductor canal. So usually the constant structures of the adductor canal is nothing but the femoral vessels, and usually the femoral nerve, which is being femoral nerves branches like the cutaneous nerves and the saphenous nerve. It's a constant content of the adductor canal. Whereas in proximal adductor canal, you can see the anterior branch of the obturator nerve, a nerve to vastus medialis. Whereas the distal adductor canal has posterior branch of the obturator nerve, and articulating branches of the sciatic nerve from the popliteal fossa enters the adductor canal. So this is a schematic representation of various levels of adductor canal. The proximal, you can see the 3 sign in the zone anatomy. This 3 sign is nothing but the meeting point of the medial border of the sartorius and the medial border of the adductor longus. This denotes the apex of the femoral triangle or the starting point of the adductor canal. So at this point, you can see the saphenous nerve on the nerve to vastus medialis within the canal. Whereas if you go to the middle adductor canal or the adductor canal proper, you can see the vasoadductor membrane separating the saphenous nerve from the nerve to vastus medialis. And moreover, you can see the adductor longus thinning out and adductor magnus taking into the position. So if you go still further down, you can see the sartorius moving more medially, and the lateral border of the sartorius meets the medial border of the vastus medialis. At this point, another clinching point to know the distal part is nothing but the descending genicular artery branching out from the femoral artery. So before the femoral artery, before leaving the distal adductor canal, gives a genicular artery branch and then enters the popliteal fossa. The approaches and techniques is the supine position with the lower limb externally rotated, and we usually go at the junction of the middle and the lower 1/3 of the thigh. So this is one anatomy of the adductor canal. This is the adductor canal proper, and where you can see the hyperechoic structure just lateral to the artery is nothing but the saphenous nerve, and the nerve of vastus medialis move away from the canal. So if you give a proper adductor canal block, you will miss this nerve to vastus medialis. First, okay, starting initially, I have marked the proximal, middle, and then the distal adductor canal. So in this video, I'm going to give a middle adductor canal block. This is the starting point of the adductor canal, and slowly slide the probe to the middle adductor canal. Okay, you can see the sartorius muscle and the femoral artery. So I enter the canal from the lateral to the middle aspect. So I just give the drug lateral to the artery, and you can see the saphenous nerve floating around. And usually the vein is inferolateral to the artery. So the next topic is regarding one more interesting thing, the 4-in-1 adductor canal block. So why a 4-in-1 adductor canal block? Because so this is a single injection technique, and whenever a dye injected in the distal adductor canal, where I have shown that before the adductor canal gives a genicular artery branch. So if you inject a dye at this level, this dye usually enters in, if you give into the adductor canal, it enters into the popliteal fossa. So this has made an interesting point that whenever we give an anterior distal adductor canal block, the drug spreads to the popliteal fossa, and it even can block the sciatic nerve branches. So, but this is a misnomer, because it's not a 4-in-1, because the nerve to vastus medialis is not blocked, because it moves far away from the adductor canal in a distal aspect. So you can see the femoral artery branching out. This is the point where the femoral artery leaves the adductor canal and enters the popliteal fossa. So this is the point where we give the drug. So the drug should displace the artery distally. This makes sure that the drug spreads into the popliteal fossa. So a short video on the distal adductor canal block. So again, I move it to the distal adductor canal. So here you can see the artery moving from the proximal to the distal and giving off a branch. So this is nothing but the femoral artery giving off the genicular artery branch. You can see the branching point of the inferior genicular artery. So in this case, I introduce the needle from the lateral to the medial aspect, and still you can see the branching point. So the drug should be deposited just above the artery. So make sure that the drug displaces the artery deeper. You can see the needle tip just placed above the artery, and drug is being deposited, and the vessel gets moves distally. So we'll come to the sciatic nerve blocks, and sciatic nerve has a root value of L4 to S3, and it actually exits the pelvis via the greater sciatic notch. And whenever it, when you see in this greater sciatic notch, so this is the area of the greater sciatic notch, it is being covered by the piriformis muscle. So this piriformis muscle covers the structures whichever exits the greater sciatic notch. And above the piriform is nothing but the gluteus maximus, and it descends between the this is the greater trochanter, and this is the ischial tuberosity. Actually, you can see the nerve between the greater trochanter and the ischial tuberosity, and you make a note of this one more nerve which comes at this point. This is nothing but the posterior cutaneous nerve of the thigh. So it has a very proximal branching point. So whenever if you give an infragluteal block or mid-thigh block, you might miss this posterior cutaneous nerve of the thigh. So the nerve descends between the greater trochanter and the ischial tuberosity, and in the lower third of the femur, it divides into the tibial and the tibial and the peroneal component. Okay. So the common peroneal and tibial nerve sometimes has a separate origin at the level of the plexus, and it gets enclosed within a common sheath. So it's a 15% chance, even if you can see the two divisions at the level of subgluteal or the transgluteal levels. And one more clinical pearl is that this quadratus femoris, which is nothing but the bed of this area where the nerve lies above this. Actually, whenever a hip dislocation happens, this quadratus femoris get torn off, and the head compresses this nerve. So whenever you see a hip dislocation patient, posterior hip dislocation patient, you should check for the sciatic nerve integrity because of the head of the femur compressing the nerve before giving a block. Okay, and on a clinical point of view, it provides anesthesia to the posterior aspect of the knee, hamstring muscles, and the entire lower limb below the knee. And the exceptions being the medial leg, which is supplied, medial leg and the foot, which is supplied by the saphenous nerve, and skin posterior to the thigh, which is nothing but supplied by the posterior femoral cutaneous nerve, which I said, which has a very proximal branching point. So this is just a cutaneous nerve. So if you are worried about tunicate pain, if you don't block this posterior femoral cutaneous nerve, not an issue, because tunicate pain in thigh is more of a muscle pain rather than a cutaneous pain. So small topic about the microanatomy of the sciatic nerve. See, in case of sciatic, whatever the peripheral nerve you take, there will be a extra layer of connective tissue covering the peripheral nerves. So in case of sciatic nerve being the largest and the longest nerve in the body, it has a thicker connective tissue. This connective tissue is nothing but a derivative of the connective tissue from the muscles, the epimysium. So this connective tissue is being called as the paraneurium. So why it is important in case of sciatic nerve block is, so whenever you give a drug in this paraneural area, the drug surrounds the nerve and it also surrounds the two divisions of the nerve. So it also it can also prevent the nerve injury caused by the block. So always target this paraneural sheath. So we'll come with the start with the approaches, and posterior approach for the transgluteal nerve block. Transgluteal approach. So you have to remember two bony points for this approach. One is the lateral most is the greater trochanter, and the middle most is the ischial tuberosity. So you can see this is the lateral aspect. You can see a greater trochanter, and here you can see the ischial tuberosity. Remember these two bony points as the tree and the hammock tied to this two trees, and the person laying on the hammock. You can see the sciatic nerve hanging like a small butt from the gluteus maximus. Okay, you should see for this hyperechoic structure just hanging from the gluteus maximus. And it's usually a triangular hyperechoic structure, and usually it will be accompanied by the inferior gluteal artery in the medial aspect. So this is also another clinching point where to locate for the nerve. And the posterior femoral cutaneous nerve also blocked at this level. So for this approach, the positioning is nothing but a lateral decubitus position with flexion at the hip and the knee, and mark the greater trochanter and the ischial tuberosity bony points, and keep the transducer between the two bony points. And this is the video showing the, this is the lateral aspect, and this is the, you can see the two bony points. This is the medially, you can see the ischial tuberosity, and laterally you can see the greater trochanter, and the huge muscle which lies above is nothing but the gluteus maximus. You can see a small butt-like structure hanging from the gluteus maximus is nothing but the sciatic nerve. And sometimes you can see an artery pulsating medial to the nerve, which is nothing but the inferior gluteal artery. So the needle entering from the lateral to the medial aspect. So on the drug spread, you can see the needle. See, the drug gets surrounding the nerve, and you can see the nerve separating from the gluteus maximus. And the muscle which lies below the nerve is the quadratus femoris, and this quadratus femoris separates it from the femoral. Then we'll come to the anterior approach. Actually, this anterior approach has been developed in case of difficulty in positioning the patient lateral for the posterior approach. And usually the anterior approach is a bit technically challenging in case of landmark or the PNS guided block because of the deeper positioning of the nerve. Usually the nerve is a part of the posterior compartment. So you have to travel either via the anterior compartment or the medial compartment, which is the adductor compartment. So you have to pass via a lot of muscles, which is more painful for the patient. Okay, that's why the anterior approach has been technically difficult in case of landmark and PNS guided blocks. Whereas in case of ultrasound, you can actually locate the nerve deeper to the adductor magnus and superficial to the So this is the positioning. Patient is supine position and slightly hip abductor and externally rotated to open up the medial aspect of the thigh. So why to choose the middle aspect of the thigh is that it is devoid of vascular structures. So inadvertent puncture of the vessels is avoided in case of a medial puncture. So this is the schematic representation of an anterior approach. So you can see the femoral artery, the femur, and the nerve. You can see the nerve getting sandwiched between the adductor magnus, huge adductor magnus, and the huge biceps femoris. And usually this at this point you can see another artery accompanying the nerve, which is nothing but the profunda femoris. So whenever you are not able to visualize the nerve, you can visualize the artery and then tilt the probe either cranially or caudally to make out the nerve. So we'll go for the sciatic nerve block in the popliteal fossa. So I think Dr. Vipin sir has discussed entirely about the anatomy of the popliteal fossa, short anatomy about this. So the popliteal vessels enters the fossa by via the adductor hiatus. So the adductor hiatus at this apex of the popliteal fossa, you can see the vessels entering the popliteal fossa. So this is being accompanied by the nerve bit laterally. So always the nerve lies lateral to the artery, and it also superior to the artery. Okay. And this fossa is being bounded laterally by the biceps femoris. So this biceps femoris crosses from medial to the lateral aspect, whereas the semitendinosus and semimembranosus is a straight descending muscle. Okay, that's why you can see the muscle crossing the nerve from medial to lateral. Okay. So in the popliteal fossa, the nerve divides into the tibial nerve, which is a superficial most branch, and it is lateral to the vein, and the common peroneal nerve, which is more superficial and lateral to the tibial nerve. And you can see an extra sheath covering the nerve. This sheath is nothing but the paraneurium, or can be called as the Volk's sheath in case of sciatic nerve. So this paraneural sheath is more prominent in this sciatic nerve. So the approaches, you can approach the popliteal sciatic nerve via three dimensions. You can go either a posterior approach, or lateral approach, posterior approach, or a anterior approach. So another clinching point regarding the popliteal nerve block. Here you can see the popliteal vein, popliteal artery, and the nerve getting divided. So the nerve which is very close to the vascular structure is nothing but the tibial nerve, and the more lateral is the common peroneal nerve. So the another clinching point of visualizing the nerve is if you flex the ankle up and down, you can see the nerve rotating. So this also can make out the nerve from the surrounding muscular structures. So another point is that the anisotropic is also exhibited at this point. If you tilt the transducer caudally, it actually brings out the nerve from the neighboring adipose tissue. So because of the anisotropy. So this point, you can see actually the block is being given just proximal to the division of the branches from the sciatic nerve. So this makes sure that the drug spreads to both the branches. Okay. But still the nerve is within the Volk's sheath. That's why just before the branching point, if you give a drug, it will be ideal. You can see the biceps femoris on the semimembranous and the medial aspect, and the vessels deeper to the nerve. So a short video on the divisions of the femoral sciatic nerve. So you can you make out the nerve here? Just follow the nerve. So you can see a joining point here, just above the artery, and it gets divided here. This is the common peroneal, and this is the tibial component. Again, coming up, it gets joined back. This is the ideal spot for giving the block. So I just show about the paraneural spread of the drug. So a single point injection makes sure that the drug spreads all around the nerve. So this is very important in case of the popliteal nerve block. See, I'm just below the paraneural sheath. This makes sure that the drug spreads all around the nerve and between the nerve also, without injuring the nerve. So once the drug has been given, you can make out the nerve because of the improved echogenicity.
So thank you, Santosh. I think we had seen some commonly given blocks. The adductor canal block, especially the 4-in-1 adductor canal block, has become the block of the orthopedic surgeon, especially when you treat total knee replacement and arthroscopic surgeries, ACL, because here we get both the components, both the femoral component and the sciatic component involved, because the drug seeps through the adductor canal to the posterior side to block the tibial plexus also. So that was a good disposition of a femoral block, an adductor canal block, the proximal one and the distal adductor canal, and the sciatic, the subgluteal sciatic and popliteal sciatic. So we have seen how to do with peripheral nerve stimulator and how to do it with ultrasound. So I think if there are any questions, we can take it. But it was a real happiness to share what little we do with all the members of ISA AP Stat Branch. I take this opportunity to immensely thank. I see Professor Kameshwar Rao here. Thank you, sir. We missed seeing you earlier, and I take the opportunity to thank all the participants and the President and Secretary, Dr. Venugopal and Dr. Srinivas, for organizing this continuously. And we are immensely pleased to be a part of this webinar series. Thank you, sir.
Thank you very much, sir. Very nice. Though I joined little late, very important block for every postgraduate and also the practicing anesthesiologist to learn the common femoral and sciatic nerve blocks, which they can apply in day-to-day practice. And there's not much questioning also, because the discussion was very clear and you have enlightened very well all the methods of block, both by the stimulator and also by the ultrasound guided. And the only thing some are asking about the dose of the local anesthetic given for the analgesic purpose and the dose for the anesthetic purpose, and regarding the additives what you are using, and please enlighten about that.
So now we will first talk about the peripheral nerve stimulator induced, because here you are not the drug around using ultrasound. So in general, the PNS blocks need much more volume than the ultrasound. So with the femoral block for a PNS, when you get a good quadriceps contraction, if it is for analgesia purpose, we use 0.125% bupivacaine 20 ml with dexamethasone 4 milligram. And if it is for anesthesia purpose, you either use 0.5% bupivacaine 20 ml or 0.75% bupivacaine. Again, you can add dexamethasone as an adjuvant. If you want to do a polycytic and you wanted to do with a peripheral nerve stimulator, and the drug that you give, again, it's enough to use 20 ml of 0.125% for analgesia and 0.5% bupivacaine or 0.75% bupivacaine for anesthesia purpose. But when you wanted to do a block with an ultrasound, and if you want to do a femoral block with ultrasound, all that you need is the drug has to surround very well. The volume can be slightly decreased, and within about 12 to 15 ml, we can give an excellent block covering both the anterior and the posterior division of the femoral. And again, for analgesia, you go with the lower percentage, and anesthesia, you go for 0.5% bupivacaine. For an adductor canal block, especially for analgesia purpose, where we use the adductor canal more for analgesia purpose, we want a good spread of the drug, especially the 4-in-1 block, which we mentioned, the distal adductor canal. We at least need a 20 ml of the drug to seep in to the posterior part, and also involving the tibial plexus. So the subsartorial plexus and this one, if you want to combine, we can give 10 ml in the proximal adductor canal, or what we call it as a subsartorial plexus, and 20 ml down. And both can be 0.125% or 0.25% bupivacaine with dexamethasone as the analgesic. For the ultrasound guided popliteal sciatic block, we need about 15 to 20 ml of the drug, and the adjuvant will be dexamethasone. The commonly used adjuvant for us is dexamethasone, and we see that it prolongs the duration of analgesia for about 4 to 6 hours more than if it is not added. So these are some of the drugs that we use and the adjuvants that we use for the different types of blocks.
Very nice clarification, sir. How much dexamethasone you are using?
4 milligram of dexamethasone, and we can actually go up to 8 milligrams, sir.
Okay, sir.
And usually the question is whether it can be given in a diabetic, and the answer is yes, because it will increase the blood sugar partially for some time, but it is not going to affect it on a long-term basis. But the advantages in diabetics are the ones who also have multiple other medical problems like coronary artery disease. So excellent analgesia makes sure that his rate pressure product is less and his BP doesn't shoot up because of pain.
You don't
There is
use
a question, can we give dexamethasone IV? That is another way of doing it. If you don't want to add it along with the local anesthetic, even intravenous
some audio problem.
Sir, can you?
Dr.
Yeah, I
Commissioner.
think
We are
I
able to
answered
hear
that
now.
question.
We are able to hear now.
Yes, sir. So any
Dr.
other
Commissioner,
questions,
sir? Yeah,
tell
one question from my side, sir.
Yes, sir.
Sir, can we perform a PNS guided adductor canal block? Can we conduct without ultrasound? PNS
See,
guided block.
Yeah, the only thing is you need to hit the nerve to vastus medialis, because every PNS block needs an proper, appropriate evoked motor response. So you can do that, but provided you go and hit the nerve to vastus medialis, see the contraction of the vastus medialis, and you can inject 20 ml, and then it will block the subsartorial plexus. But
Sir,
it is not as effective, probably because of the so much of anatomical variations. It may not be as successful as a femoral block.
Balvankat sir, please correct me if I am wrong. But when we are conducting PNS blocks, most of the times we will search for a landmark and bony landmarks. But for here in adductor canal, there is no bony landmark.
So that's the problem. That's the problem. That is the problem. That's why the failure rates are very high. So yes, PNS is always good when you have a palpable artery close to it, or you have a definite landmark close to it. That's why all the PNS blocks, to keep our morale very high, we have to choose the right kind of block so that the surgeon feels that you're a good anesthetist.
Yes, sir. Yes, sir. Yes, sir. That Commissioner, sir, one more question from my side. In a femoral nerve block, if we with a PNS, if you go superficial to the fascia, can we get a twitches?
No, actually, basically, as it was clearly described, you definitely will have a fascia lata and fascia iliaca you have to pop in. Yeah. So then only when the tip is close to the neural tissue, you will get it, especially at 0.4 milliamps. If you're getting it, you are sure that you have pierced both the fascias and you get a contraction of the quadriceps.
Fine, sir. Fine. Thank you, sir. Thank you very much, sir. Commissioner, what to you?
Can you use other additives like dexmedetomidine and clonidine and all these things you are not preferring?
Butorphanol?
Sir, actually, multiple adjuvants are used. The advantage of dexamethasone is that it does not produce any hemodynamic changes irrespective of the age. Whereas dexmed and clonidine have got the propensity to produce mild bradycardia and hypotension. In a large center like us, when we do large volume of cases, we don't want any aftermath of this. But having said that, under control, yeah, dexmedetomidine also has been found to be a good adjuvant for perineural tissues with about 1 microgram per kg added to the local anesthetic solution.
Correct.
Thank you, sir.
Thank you, sir. Very nice lecture. And,
thank you, sir.
Very useful for everyone.
Thank you, sir.
Thank you.
Such a pleasure being a part of this webinar, and look forward to being with you again after a couple of weeks.
Sir,
Thank
can
you
I
so
ask
much.
one question? Sir, can I ask one question?
Commissioner, please.
Sure.
I'm Dr. Ramtani from Nagpur. Very nice presentation, sir. First of all, I want to congratulate. Whenever I used to give lower limb blocks for post-op analgesia in some of my patients in orthopedic surgeries, some of the orthopedicians always had a question towards me that what about the signs of compartmental syndromes? Because your blocks will mask our signs, and we will not be able to diagnose those patients. So what about
No, that's a very important question. And the lower limb compartmental syndrome are always associated with upper tibial fracture, tibial condyle fractures. So because here there is a lot of oozing, and the compartment becomes very tense and the vascularity gets impaired. So as far as the lower limb is concerned, whenever you're going to give a sciatic block for an upper tibia fracture, Either you monitor the patient closely in the post-operative period for development of compartment syndrome, which we normally do it by using the probe, the pulse oximeter probe, put it in the lower limb so that it picks up any vasospasm, or intermittently you have to monitor the compartment pressure. Like monitoring the intra-arterial pressure, the same transducer can be used to monitor the intra-compartment pressure. And if the pressure goes more than 30, it needs a fasciotomy. So if you are working in a center where you cannot monitor, best is to avoid a sciatic block for a upper tibial fracture. Apart from the tibial condylar fracture, there are no other fractures in the lower limb which goes in for a compartment syndrome.
No, in few patients I used psoas compartment block actually. Psoas compartment block I used for a few patients, and I used ropivacaine in those patients. So,
but psoas compartment block will not produce anything to do with the tibia fracture.
okay.
It is more of lumbar plexus actually.
Yes, it is one kind of a lumbar plexus. Okay, thank you.
Yeah, thank you.
Thank you very much, sir.
Yeah, thank you, sir. Thank you very much, and look forward to seeing you all again.
Thank you, sir. Thank you very much, sir. Dr. Kameshwara Garu, Dr. Bal Venkat, sir. Really very happy to hear all the things today. We are learning one more point every time. Thank you very much, sir.
I want to greet Dr. Venkatgiri, Dr. Chakra Rao, and who are all the national leaders who are on the form now.
Yes. Nice to see Dr. Chakra Rao spending time with the blocks.
Dr. Srinivas, are you there? Dr. Srinivas? Secretary, Dr. Srinivas, please do complete vote of thanks. Dr. Srinivas, Sursetti, please do vote of thanks. RS, Dr. Kameshwara Garu.
I thank first of all Dr. Bala Venkat for these time-sparing efforts, because I know he's very busy, very involved even in this COVID time with so many lectures, the webinars, and in spite of that, he has got the affection towards our state branch and participating in all the webinars. Particularly, I must appreciate Dr. Venugopal and Sursetti, the constant drive. Otherwise, it is not possible to conduct so frequently so many academic sessions. And I thank Dr. Bala Venkat and all his team members who are participating in this very useful academic program for every practicing, every anesthesiologist. Thank you very much, sir. Thank you, one and all.
And Dr. S.P. Chittora from Jaipur, and Dr. Atmane from Nagpur. Thank you very much, sir.
I thank all the participants from other states also who participated in this webinar.
Thank you, Dr. Chakra. Thank you.
Thank you.
So nice
Thank
of
you,
you.
sir. Thank you, sir.
Thank you, sir.
Thank you, sir. We close the meeting.
Thank you, sir.
Thank you, sir.
Okay, sir. Good night, sir.
Good night, sir.
Kishan gadu chide enakal unnada.
Dr. Kiran Kumar.
Kishan maatladava. Kiran Kumar aadi kesu poyi untadu.
Okay.
రేపు 24 గంటల కర్ఫ్యూ.
Thank you very one and all.
Thank you very much.
పోవడంతో డెఫినెట్ గా
Thank you all.
ఎవరమ్మా?
Thank you.